Thank you for inviting me to be here. I'm very happy to be participating in this meeting. I'm going to mostly talk about my experience in Zambia and then also just reflect a little bit on how it has impacted my career path at this point in my life. Okay, so just starting out with a little bit of background, before my experience with the Fogarty program, I had sort of dabbled in international health, but hadn't found a way to really make it a part of my life. I had always been interested in language study and travel. In college, I went to Ecuador through Child Family Health International and spent some time shadowing. And then in medical school, I got involved, well, actually helped found the Kenyan Pediatric HIV Project that we had at University of Pittsburgh. A friend of mine had gone during the summer after our first year to do some research there and came back and just had these horrible stories about all of the children infected with HIV and that nothing was being done about it because at that point in time it was before antiretrovirals were there. And we got very far ahead of ourselves and initially thought that we were going to be able to raise money and provide ARVs and do all kinds of things, but thankfully we had 3 really fantastic mentors at Pitt who guided us through that and redirected our interest to helping to provide supportive care there. I was involved in the Global Health Interest Group as well as the chair of the Journal Club, but again, these were all sort of short-term limited experiences there. As far as the Kenyan Pediatric HIV Project, I think that was one of the things that really inspired me to find a more meaningful experience after that. Not that it wasn't meaningful, but you know, we spent all of our second year raising money, doing research, figuring out what we were going to do, and then really it was just a 3-week fact-finding trip, looking into the site, figuring out how we were going to become a part of that and how we were going to continue after the rest of us graduated, because being medical students and knowing we had residency ahead of us, certainly it wasn't going to be something we could continue doing. And we ended up passing on that leadership to subsequent groups of medical students, and it's still an organization now at University of Pittsburgh. So that said, having had a 3-week experience, I think we all felt a bit empty when we came back from that and knew that we were interested in so much more. And actually, Kate Dickman, who is in the purple shirt there, and I both applied to the Fogarty program, and she was matched in Uganda, and I went to Zambia. So my experience was from 2006 to 2007. I was working with the Cervical Cancer Prevention Program in Zambia. This was not a project that was meant to have a scholar necessarily, as it had just been started in January of 2006. The first 2 sites were established at that point in time, and another 2 sites were established in April of that year. So at the time when we were interviewing, the 3rd and 4th site were sort of just being established and the project was just getting off the ground. So my time was spent there very much working on the infrastructure, working on program expansion, helping with nurse training and development of resources. I put together a training manual as well as educational pamphlets and posters and really just tried to move the program forward and get it out there so that we could have more screening of Zambian women. Prior to the cervical cancer prevention program in Zambia, there was no nationalized screening program, and cervical cancer is the leading cause of cancer-related death in women in Zambia. So just to go through sort of stepwise, as far as the infrastructure goes, we modeled ourselves after the HIV treatment program that the Center for Infectious Disease Research in Zambia already had in place. They had integrated themselves into the public health clinics, and we recognized that that was a very meaningful way of getting involved in the community and also reaching out to people where they were already used to going for care. We didn't want to set up a parallel system, but rather incorporate ourselves into the system that was already existing. So we worked with community members, stakeholders, clinic staff to try to get everyone on board, and every time we opened a new clinic, we would have meetings with all of these people to make sure that they understood what we were doing, that what we had to offer, and ideally collaborating as much as possible with those people. We also had volunteer peer educators that we recruited from those communities. For each clinic, we found 1 or 2 people who lived in the surrounding area and knew the people and knew what would work to reach out to them, who we got on board to participate. Sorry, my screen went blank. I'll look at this one. As far as the task shifting concerns, I know that's kind of a catchphrase that's used a lot, and it was really a huge part of our program from the beginning. We knew that there was a limited amount of physicians in Zambia, and that the best way to go about reaching a lot of women and getting screening accomplished would be to have nurses serve as the primary screening providers. So our modality that we selected was visual inspection with acetic acid, and you can see the nurse holding a camera there. We did this with adjunct digital cervicography. So the nurse would apply the acetic acid to the cervix and then use the camera to take a picture of the cervix and also magnify that, project it onto the television screen, and be able to use it as an educational tool for the patients as well as a diagnostic tool. As part of that, since the nurses were working on their own in the clinics, we also had to have a lot of quality assurance and continuing education. So you can see the picture on the right side is one of our very early on weekly meetings. At the very beginning, we met in Dr. Mulindi Monahamuntu's office. He's the one pointing at the computer monitor and looking at the image. We quickly outgrew that room, but for the first 6 or 8 months that I was there, that's where we had our weekly quality assurance and continuing education meetings. As far as the peer educators are concerned, they also had an intensive training program before starting to work, and then they would go around the clinics and into the communities with pamphlets, brochures, and really sharing the education that they had gained in their training sessions with the community and trying to get women to participate in the screening program. There were a number of milestones that were reached during the time that I was there. First, it was sort of on a personal level, and about January, which was probably halfway through my Fogarty year, I decided there was no way I could leave and I needed to find a way to stay for another year. I was just, too involved in the work and was loving my experience, and there was so much more that I wanted to do. And so at that point in time, I approached my mentor, who had already been joking about me staying and that I wouldn't be leaving, and said, no, really, that's what I'd like to do. How can we make this happen? And so thankfully we were able to find some funding, and a position was created through UAB for me to be able to stay a second year and work at that site. Around the same time, actually it was later in the same year, we hit 10,000 women screened. And that was a huge celebration for us because in 2006, which was the first year of the program, we had screened just over 3,000 people. Well, through all of our implementation and scale-up efforts, in 2008, we screened more than 3 times that number. And so that's how in 2007, we were able to screen 3 times that number. So that's how we hit the 10,000 women within the second year of the program's existence. Also, during my first year, during my Fogarty year in Zambia, I put together a proposal for a prospective study of healing after cryotherapy treatment for HIV-infected women with ablation-eligible lesions. It took a little while to get that off the ground, getting the IRB approval, getting approval from the Zambian Ministry of Health, but it did eventually get started, and it's currently still enrolling participants, but nearing completion. So hopefully I'll be able to analyze that data and get that published sometime in the next year or so. As far as the program progress since that time, we're continuing to screen more and more women every single year. Although that 10,000 was a huge celebration at the time, we now just hit 50,000 last week. So the program has continued to grow exponentially. We've also found that there are other things that we need to incorporate into the program. One of those things is HIV testing and referral. We found that there were a huge number of our participants who had come for screening and didn't know their HIV status, or maybe they had been tested 3 years ago but hadn't been tested anytime recently. And so we started offering in 2008 diagnostic counseling and testing whenever a woman had an advanced cervical lesion or had risk factors that were possibly leading to HIV. She was offered HIV counseling and testing right there by our cervical cancer screening nurses. And then any who tested positive were escorted to the other side of the clinic where the HIV care and treatment center existed. So we tried to collaborate with our HIV focused colleagues in that way to be able to refer patients to them. And in the same token, they referred women to us. If somebody came for ARVs who hadn't been for cervical cancer screening yet, they would send them over to us so that they could be in the screening program. This is a very busy slide, so you don't need to read through it all, but this is part of the research that I did during my time there also was looking at establishing a referral center for women who had cryotherapy ineligible lesions, so looking at those who needed to have excisional therapy. And this was a pretty big task in that there are a lot of complications in setting up an outpatient surgical treatment center in a country such as Zambia with resource limitations, with irregular electricity, with water outages at times, with difficulty getting supplies. And so we put together sort of a list of all of the challenges and also the solutions that we had come up with, which I'm sure are not the only solutions to those problems, but were the ones that we found and the ways that we managed to get this referral center set up. And then also in looking at the same center, we wanted to make sure that we were offering a quality service. And so we did a retrospective study looking at the complications of the procedure and found that really our complication rate was very low and was comparable to that existed in high-income countries. As far as the program right now is concerned, we've continued expanding throughout the country. There are now 17 clinics within Zambia. There are 12 in the capital city of Lusaka and 5 in the rural areas that are offering screening. But we also began participating in international expansion efforts. The first program that we worked with was in Cameroon, and we were providing training where they would send a nurse to us, and we did some training with him, and then we went to Cameroon and offered continuing training there, and then served as collaborators and consultants using email and electronic distance consultation. That was the beginning of a larger electronic consultation system that's in place now, and that has continued to expand since that time. And I do have a poster regarding that system at this meeting today. So at this point, we've had 59 nurses and 19 physicians from 10 different African nations and the People's Republic of China come to train with us and have us go and help them in their locations to establish similar programs. As far as the impact on my career, when I went to Zambia, I was between my 3rd and 4th year of medical school, and I was shocked in my 3rd year to discover that I was interested in obstetrics and gynecology. Somehow I never saw that on my radar, and I didn't expect to like that. And so I think participating in a cervical cancer screening program was fantastic in that it did solidify for me that that was really what I needed to apply to when I went back to complete my 4th year of medical school. But in addition to that, it has sparked an interest for me in gynecologic oncology, and I plan to pursue a fellowship when I finish my OBGYN residency. And also, same as Jerry was suggesting before, it's created a lot of relationships that have allowed me to continue my research during residency, even with the work hours that we have and being on call and everything else. Having already formed those relationships and having already started the research, I'm able to continue it, not on the same level, but I'm still able to continue it while I'm in my residency program. So I think for me that's it. I'd just like to thank everybody who participated in funding me or providing me support during the time of my fellowship.